We're at the IAS meeting in Kuala Lumpur. We're appreciative that Annette Sohn from AMFAR, the Director of Treat Asia, is going to be here with us and talk a little bit about, give us an overview of your position there and what AMFAR is doing with Treat Asia, and then we'll talk specifically.
Sure. So Treat Asia, as you mentioned, is a program of AMFAR. And a number of years ago in the late 90s, when AMFAR was looking to expand its global reach more internationally away from U.S. domestic priorities, our leadership started looking at where there were gaps. And there were a lot of gaps in Asia, but there were a lot of people supporting work being done in Africa. We just didn't see the same thing in Asia. So AMFAR decided to make a very strong commitment at that point to research, education, training, and civil society in the Asia Pacific. And so now the Treat Asia Network includes about 60 institutions across 13 countries, everywhere from high-income countries like Japan and South Korea to low-income countries like India or in Cambodia. And across those sites, we conduct a range of different types of HIV-related outcomes research and epidemiologic analyses, as well as training for providers and community treatment literacy. We also do a fair amount on advocacy, in particular with regards to hepatitis C treatment for HIV co-infected individuals, which primarily affects key affected populations, such as injection drug users and MSM.
And have you been part of this building the collaboration? Would you consider it a collaboration?
Yes, so we really consider the core of what we do as being a network, whether it's a research network or working with a network of community partners. I personally have been with Treat Asia for about 5 years, but the program really started in 2001, so we're now at over 10 years of this kind of network building and capacity development in the region.
Now, can you talk specifically about the work that you're doing regarding pediatric AIDS? Because that's, like we said earlier, this is really a focus of the IAS, this particular meeting.
Yes. So in fact, the very beginning of the Treat Asia program was focused on adults, which can be understood because adults dominate the largest proportion of the epidemic within the world and within the Asia Pacific too. But we felt in about 2004 that we kept having people come to us and saying, well, what are you going to do for the children? Nobody is really supporting us with the kids. And this was before the U.S. government really started working on PEPFAR activities in Vietnam and in the region. Global Fund was funding activities in Cambodia, but it was still pretty limited in scope. And middle-income countries like Malaysia, Indonesia, they didn't really have much support for research or looking at evidence-based outcomes. And so we went in and started creating a pediatric observational database. So now we have a database of 4,000 children with HIV, and we are able to study things like their antiretroviral therapy regimens, side effects of these regimens, but really importantly, where they are when they come in to see the doctor. And so, you know, the WHO has put an emphasis on treating all children under 5 now, but the critical time period is to treat children before they hit 12 weeks of age. And our early infant diagnosis, our prevention of mother-to-child transmission, even before that, in the region lags behind sub-Saharan Africa. And so despite the fact that we have a lot of middle-income countries in our region, we're doing worse than sub-Saharan Africa, which I think is really just something that should shake people up and have us start looking more carefully at how we're supporting the infants, children, and adolescents in our region. So in our database, about half of the children in the last 3 years started antiretroviral therapy at the age of 5 or above. And so that means we're really missing out on the younger children. And so what we're trying to do is work with the local doctors to teach them about how to diagnose and manage children with HIV. We're also looking at drug resistance. So we don't have more than 2 regimens, really, first line and second line, in most of the areas in low and middle income country settings. And so we can't afford to have them fail second line therapy and then need a third line. But the reality is we know that that will happen. So we're trying to study resistance now so that we're prepared for the future.
So you don't really have a problem with adherence within this population, is that true?
I think that all populations have problems with adherence. It's probably the single most important indicator of whether or not an individual patient will be successful on therapy, and in aggregate, whether or not you will have program retention over time. We also have problems with adherence, so I think that maybe as for pediatric patients in particular, they rely on adult caregivers. And so if our adult caregivers are not in good health, they are sick, they can't go to the hospital, they die. And then these children need to be taken care of by relatives. They may end up being institutionalized. We heard today at the IAS conference from an adolescent girl, 19 years old, who was born with HIV. Both of her parents died, and her grandmother threatens her that if she disobeys, she will stop her treatment. And so this is, of course, unique. Most of the time, the grandmothers are trying to get the kids to take their treatment, but I use that as an example of how we have the whole spectrum in pediatrics. These are kids who are not independent. They're very vulnerable. They have to rely on people around them to help them to take care of their disease management and disease control.
How do you decide where you're going to put your efforts, specifically, regionally, or specifically in cities or groups or communities, or however you want to put it? Because it seems like you're tackling a very, very large section of the world.
I think the first point to make is that AMFAR's priority is really on research, and although the Treat Asia program is able to do activities in training and advocacy, as I mentioned, our primary focus has always been research. And so that does limit to some degree the places that are able to do research, that have sort of the more formal infrastructure for at least basic data collection. And so that does to some degree limit where we're working. But our primary focus in the pediatric program is really in Southeast Asia.
Which would be?
So we work in 6 countries in Southeast Asia. I guess that includes South Asia as well, with India, Cambodia, Indonesia, Malaysia, Vietnam, and Thailand.
So how are you liaisoning with the government? So do you find much pushback there, or do they welcome you with open arms?
I think one of the priorities for our program is that we work directly with local clinicians, local researchers. We work through the people who are going to have to be responsible for sustaining their program. So we're not like a development agency in that sense. We completely invest in the local doctors, and so we rely on them to be sort of the conduits or the bridges to the national governments. We do have a formal relationship with NCHADS, the government program in Cambodia, and so that has been going on for a number of years now. But outside of our relationship with the Cambodian HIV national program, we tend to work through the centers. But many of the doctors in our centers are investigators. They are the lead writers of their country's national guidelines, whether it's for pediatrics or adult. So we feel that working together with them and empowering them is a key priority for us.
How do you connect with the community itself? Do you have, we talked about our community advisory boards earlier, but is this something that you, because you're doing research, do you have some sort of a community committee, or by country or by community?
Yeah.
How does that work?
As I said, we really try to work through the individual hospitals, but at the same time, we try to create structures that encourage them to link more directly with community. As one example, we are conducting an NIH-funded study on human papillomavirus in adolescents that's funded by the National Institute of Child Health and Human Development. We just started. We're coming to the end of year 1 out of 5, and that's looking at teenagers in Thailand and Vietnam to look at sexual risks, human papillomavirus infection, and cervical precancers to try to provide data to support vaccine programs in the future. But as a part of that research program, we are meeting with community advisory boards that already exist in Thailand, which has been a great opportunity for us. But in Vietnam, there is no CAB set up. So instead, we set up a community outreach meeting. We try to talk to the community members before we finish the protocol and the consents ahead of time to make sure that their feedback got integrated into our research plan. And we will, over time, continue to reach out to that community. So they don't have a CAB in the formal structure of the word, because nobody's ever ever reached out to them to suggest
don't understand the concept,
that they make
yeah.
one. I think that if you explain it to them, they would absolutely get it. The community in Vietnam is very savvy, but it hasn't come up. An opportunity hasn't arisen. And so what we're doing is we're providing an opportunity, and a great outcome for us at the end of this study would be that Vietnam develops a CAB for pediatric HIV research.
And the funds for this project that you're doing, is this from your general fundraising efforts?
Yeah.
Comes right into this?
So-
This is where you must spend a large part of your resources.
So this particular grant itself is funded by, as I mentioned, the U.S. National Institutes of Health. But a lot of what AMFAR does in the Treat Asia program is supported by AMFAR fundraising efforts around the world. And so that includes people sending in a check for $25 or a high-profile celebrity event at a film festival or a fashion event. And so all of that gets pulled together, and we definitely benefit from the funds that are raised through those different mechanisms, which is predominantly done in higher income settings, but those funds are utilized by us to promote our research and programs around the world.
Before we end, I just want to give you an opportunity to toss in there any other discussion you might want to have about AMFAR itself, because I appreciate the work you do, and I think that it's wide-ranging, but also limited in your case, because that's what you do. You do the Treat Asia section.
Yeah. So I think the top priority on AMFAR's list right now is to find a cure for HIV. And what's very exciting to me is that for the first time, researchers in Asia are actually part of that. So Dr. Jintanat Anandwarnich at the Thai Red Cross AIDS Research Center and the Military Research HIV Research Program of Adherence received part of a grant from AMFAR under our ARCH HIV Cure Research Consortium. And so, again, this is the first time that an Asian researcher in Asia will be at least partially funded through an HIV Cure grant through AMFAR. So I do think that we have a lot to add within our region to what's happening in HIV Cure research in the future, and that's really where AMFAR's primary priority is right now, to find a cure.
Well, that's where we'll end, because that's where we're just at the beginning
That's right.
of the cure work. Lots of work ahead. Thank you very much, Annette.
Thank you.
Appreciate it.
Thank you.